So reform, so we're gonna reform now. So what is actually reform, what do you do when you're reforming things? What, by the way, what parts of the world would, if you were gonna be in the World Bank or whatever, what part of the world would you not go into the countries and say, I'm here to reform you?
Switzerland.
No, it's okay. There's a whole region of the world where you wouldn't do that.
Asia.
No,
Maybe
it's
Central
okay, it's okay, actually okay, in Asia it's okay.
Middle East?
Yeah, Middle East. You would not go to the Middle East and use the word reform. Why wouldn't you? Anybody?
Is it because the word reform is associated with Western culture?
Okay, you're close. It's because the word reform is interpreted as you're criticizing something that isn't working. So what you're doing when you do that, you're telling people, hey, what you're doing is not good. We're going to now come and tell you how to do it better. Okay, so we've got the answer to things. And
Isn't that what the World Bank did in Morocco?
well, you wouldn't go there and tell them you're going to reform. You tell them you're going to give them some money.
I thought that there was conditionalities on the money given
yeah,
related to
well,
reform.
there is, but you wouldn't necessarily use the word reform. Okay, so cultural sensitivity, you'd be very careful in the Middle East about the words you use, because otherwise, you're going to lose your client right away, and they're not going to listen to what you have to say. Now, Morocco is a
What
little
about
bit
Israel?
different.
That's not the
No,
Middle
I
East.
say you can bash them to fits, and it's okay. They have Russian anyway, so you know it's okay. The Russians are not particularly sensitive. So, okay, so reform now, first of all, it's a word that has stigma attached to it. So you have to be kind of a little bit careful about how you throw around the term reform, because it means that, you know, you're suggesting that what they have is not good, and that, you know, what you might be suggesting is better than what they have. So you have to be a little bit careful about that. But I think the other thing about reform that is particularly problematic, so my first assignment in the World Bank was Eastern Europe, okay? At a time when the Soviet Union collapsed. Okay, so my first trip to Eastern Europe was actually in 1989, before the curtain fell in Poland. We met with some Polish leaders at that time. All the countries had universal access, everybody had access to healthcare. Life expectancy was high compared to other countries at the same income level. So, you know, there was a lot of problems in Eastern Europe, but if you took Russia in 1990 and compared that to Brazil or to you know, other countries at the same level, you would say, wait a second, I mean, this country is doing really well in healthcare. You know, I mean, high infant mortality, high under 5 mortality, lots of really good stuff in terms of healthcare. Everybody had access to services, high vaccination. I mean, they had 99% vaccination rate. What is it here in the US?
91 to 90.
You're being generous. It may have gone up now. Well, yeah, okay. But not too long ago, it was 75, right? So it's come up, but it's 90, so it's good. But they were 99, right? So we then came in the World Bank, with these huge packages of money saying, we're going to help you reform the health sector.
They said it's fine.
Well, no, actually, they didn't think it was fine because they thought it was terrible.
Oh, really?
They all wanted the money because they wanted to reform the health sector. So what, in Russia, when you're looking at the Russian story here, what is it that Russia was trying to do to reform their health sector to achieve universal health care?
Privatization.
But let's keep the objective. The objective is universal health care, right? So, I mean, reform, you have to have an objective, right? So what is the objective you're trying to do in Russia?
Reach everyone?
Sorry?
Improve quality.
Increasing funding?
Was that what they were trying to do in 1990?
Oh, no.
So did they break the system and you have to redo it, or what happened? So, I mean, because in 1990 it was
I'll give you my interpretation, and Karin,
Yeah.
originally from Russia, can give you
Right.
his. And we'll have a session about that. But if you start with the premise that it was universal.
Was it
in
universal?
In
It was
principle.
universal during the
According to the
Soviet Union.
Constitution, yes.
Right. No, but actually
Constitution, yes.
also in fact. I mean, everybody had access to services, right?
No, not everybody had,
That's not necessarily true.
different people had access to different levels of services. There was a great inequality, the nomenclatura had one kind of
Yeah.
access,
Like, and
It
peasants
also
had
varies by
another access,
republic.
urban had different access,
But the-
productive
But the
workers had
total,
higher
the
access.
total, the average level was so low anyway, that you're kind of splitting hair at
No,
low
it
level,
got
right?
much higher.
Yeah.
It was highly inequitable, highly unresponsive, and therefore the objectives of the reform, I would say, are quite different. And the word is used very differently in different contexts.
Mhm.
So in that context, the reform was, how do we improve the quality? And
That
how
wasn't
do
the
we-
reform, that's not the reform we did when we went in 1990. It had nothing to do with quality, right?
The bank,
No. That word wasn't even part of the vocabulary.
Access?
responsiveness,
No.
budget.
upgrading,
versus-
upgrading.
Technology,
You get it.
facilities.
I said it?
Yeah.
Yes. Uh,
Privatized and
Privatize it.
bring in markets.
America's.
Yeah, but why?
Oh, but they didn't care about it. That was
I
not,
just wanted to mimic the Western countries.
that was not part of the
I mean,
story.
that-
It was not quality, it was not more access, it was, you know, it was bring in markets.
No, but there was an implicit notion.
Not
To
really.
my reading,
not-
that
yeah.
when you privatized, you would create more responsiveness and you would upgrade quality. and
That's
you
what
would
the
raise
academics were saying,
capital.
that's what the
Yeah.
academics were saying.
But I'm an academic.
Yeah, that's what I said too, I went in there with the same thing,
Yeah.
but that's not what the Russians said, it's not what the people in Hungary
That
said.
that was a rejection of the state, of course.
Yeah, absolutely.
Politically, it was a rejection of the state.
It was totally a rejection
Anything
of
that
the
the state
state.
did was wrong.
It
We
was
now
a-
change, we want
It
to.
was a rejection of the state, okay?
Kari, what's your interpretation?
Regarding the healthcare reform in Russia.
Yeah,
Um,
no, just.
At that time,
so basically, like after the fall of the Soviet Union, the Russian government technically really wanted to privatize the health
Yeah.
system, and
they wanted to privatize everything, right, not just the health,
Yeah.
everything had to be
That's what
privatized,
happened in
why?
Ukraine.
they just wanted to mimic the Western countries at that time.
Yeah, because they saw their
They
cousins
thought that would be
driving
better or
limousines and Mercedes-Benz in Germany, and they said, look, if we privatize the system, we can have a much better system,
But this reform didn't much like they were basically.
high-quality clinics, you know,
You
public
just use quality.
well, you know,
Yeah.
consumer quality. Consumer quality. Consumer quality.
But this reform didn't do much.
No, it didn't work.
It didn't work. They
No,
basically
no,
did
absolutely, it didn't
more
work.
harm than.
But the original motivation was to bring in markets, right? I mean, that was the motivation.
It was a good idea.
So, yeah, I mean, that's what they were trying to do. I mean, you could now go to, you could kind of go to, I mean, you can go now from you know, you can go now from Russia to China, because really, the Chinese story is not so different, right? Because China, at the time of the Barefoot Doctors, had pretty well universal access to healthcare, and it was constitutional, whatever. Probably the Barefoot Doctors are a bit overrated, because it's not quite clear whether they were really giving good services. But, you know, whatever's the case, that's the kind of rhetoric at least. And then eventually, you know, the system kind of unraveled, and, you know, and you're now in a situation where, you know, large parts of the population don't really have access to healthcare, but, you know, the system is still there, it's a universal system, which is highly fragmented. Brazil is a bit more complicated, because Brazil didn't really ever have universal, and then they kind of brought in a constitutional reform, and they made it universal, but, you know, in some ways, probably today, Brazil is in fact more universal than Russia, India, and China. Despite the fact that it's not universal, you know, but probably Brazil, are you Brazilian?
Yes.
Okay, so probably in Brazil, it's not gonna be that, how can you reform, what do you do when you reform something? Let's look at reform a little bit more, to kind of figure out what it is you do. Say you're appointed by your government to be the Hillary Clinton of the first Clinton reforms, and you now have to do it, okay? So what are your choices for doing that kind of thing? Yeah,
So as speaking for India, I would say that the system over there is very fragmented, and there is no, like, it's so scattered and the roles are not connected.
right,
So that actually leads to like rising costs for healthcare, but the country is not getting that better outcome or quality as compared to the cost they're spending.
right,
And this is like one of the biggest rising concerns for the country, because just like US, the costs in India also like are rising, but on measures of WHO or the organizations that keep a check on the burden of disease in the country, communicable, non-communicable, infectious. So it's still not improving. The outcomes are not improving.
So does that mean India has low quality care or high quality care?
It's
I mean,
again-
we're deviating a little bit away from the reform. I want to come back to the reform in just a second, but since you brought up the India, does India provide low or high quality care?
they do have high quality care. It's not, the infrastructure is not strong enough
Uh-huh.
to provide it universally, so that
Okay.
everybody can benefit.
So this is an issue. I mean, I have a beautiful story about India, by the way, because I worked quite a bit in India, and I was visiting Bangalore.
Mhm.
Do you know the Shetty, Dr. Shetty? It's
The-
a health city.
yeah.
Have you ever been there?
No, I haven't, but I've heard a lot about
Okay,
it.
so I went to Health City. A fascinating, you know about the Health City? You been there?
We're gonna talk about it a little bit next week.
Okay. Oh, you're actually gonna talk about it. So you don't want
on
to,
India next week.
do you want me to spill the beans or?
Go ahead, go ahead.
Okay, so I was in a meeting and this have you met Dr. Shetty? So it's quite a modest, gentleman was in the meeting, and at the end of the meeting, he comes up to me and says, "Would you like to visit my clinic?" And I said, "I'd love to visit your clinic, but I'm actually busy." I'm doing other things. I don't have time to visit your clinic. I didn't tell him that, but I said I'm kind of busy. I was actually busy. I wasn't just being snobby. I was, I had a lot of things to do, and he wanted me to visit my clinic. So I didn't get. So I agreed to. I was going to go visit his clinic, and I went to see his clinic, and lo and behold, he wasn't there. So he sent his chief resident to come and greet me. And he said, well, this is a cardiac clinic. I'll take you to the cardiac post-op first, and we'll just see what's going on, and then we'll take you around the facility and whatever. So we go to the cardiac post-op, and it blows your mind off. There in the cardiac post-op are 80 kids that have just come off the knife that day. 80 open heart on kids that day. And then 30 or 40 whatever adults. So there was like 120, 110, 120 open heart surgeries that day. Okay? What do kids get open heart surgery for? Septal defects, right? Okay, it's something fairly simple, okay? And you just have to close the hole because otherwise the kid dies. And so that's what he does. He does that, and so he does huge amount, and it was amazing. The quality, you wouldn't believe the quality of what care you would get there.
Is this the same Dr. Shetty that has the hospital chains in the United Arab Emirates?
No, that would be Reddy, I think.
It's Shetty, but
Oh, is it Shetty?
I don't know.
I don't think he has, because it's kind of a one-off thing,
Okay.
the Shetty one. It was really, you really wouldn't go into a US intensive care area, which would have more than what we saw there. So it was really top of the end. Every kid that came off the knives had 2 or 3 nurses full-time on the kid, full life support for every bed. There was more intensive care than you would ever get in a US setting. And then, it was process engineering was amazing. You move from one place, first day post-op to second day post-op to third day. Each one was a different type of care. And then after that, of course, the kids were released. Then we went to, the hip replacement thing. They do 300 hip replacements a day, 500 cataract replacements per day. And then we went to the outpatient department. They do 4,000 outpatients per day. And the extraordinary thing was no waiting list. It was not like there were queues. It was there. I'm giving this as an example because we're talking about reform, right? Okay? So afterward,
One question here, the people pay to get this service.
okay, we're coming to that. So afterward, after I'd seen the visit,
Yes.
we go and see Dr. Shetty in his office, and I said, very interesting clinic you have, You could have told me a little bit about, when you invited me to your clinic, you could have given me a hint, what you were going to show me. And so we sat down, and I said, well, what can we do for you, the World Bank? And he said, well, I want to build another 14 of these. So he wanted some money. So, of course, for me, this is a good deal. I'm there to show him money, and he wants some money, and it looked like a good deal. So I said, let me understand the business case a little better. I want to kind of, understand what's going on. I said, well, how do you pay for this?
They're bleeding money.
So as an economist, of course, the first question I ask is, how do you pay for it, right? So he says, well, actually, 65% of the kids that are here, we do for free. It's a social service, we just do it because, you know, the kids need to have the care. And 30% of them, we charge them at cost. And so I said, well, what's your cost in India? And he said, $2,000. So what's a bypass surgery in the US?
150,000.
It's around 85 to 130, depending on, you know, the surgery. So they do it for about 2,000. And then I said, okay, 30 plus 65, that's 95. We're missing 5. So what happens with the other 5? And he said, oh, that's where we make our money.
Is it medical tourism?
So I wanted to see, so I said, well, can we see what you do for that 5%? I'm kind of curious what you do. And so he said, well, we don't usually show this, but, you know, since you're the World Bank and I want enough clinics, you know, we'll make an exception for this. So he takes me into this thing that looked like the Star Wars control center. And they couldn't have put more equipment into this thing with more whatever. And there must have been 20 surgeons and nurses and they all whatever. And there was some rich guy from India that was getting a liver transplant. Okay? So I said, oh, that's very interesting. I didn't know you had capabilities in India for doing liver transplant because, you know, that's well known in Taiwan and Thailand, but not in India. I mean, I didn't know they did that sort of stuff. And he said, well, actually, we don't. So he said, well, you see there, the surgeon is in where?
Thailand?
No,
Taiwan?
Philly.
Philadelphia.
Okay, the surgeon was sitting in Philly. So it's robotic surgery on liver transplant with the surgeon.
Philadelphia.
Yeah, Philadelphia. Okay. Okay, now let's talk reform in India, right? Okay, so clearly India has the top of the end, okay, as a benchmark, and you got the worst of the worst, right? So what would you want to do to reform that kind of a system?
Just one parenthesis, in preparation for next week, there's a reading by Lawton Burns, Professor Burns in Philadelphia.
Okay, maybe he's the one that does the
No. He like, is an economist at the business school.
Ah, okay. Oh, you actually know him, actually.
You probably do.
Yeah.
Supply chain management.
Right, very good.
And he's written a big book
Yeah.
on the private sector in India
Mhm.
that makes it look as if this is I mean, he knows it's not, but one would think that this is India.
Yeah,
It's only, as you say, one facade,
But I have
an
to
important one.
Yeah, absolutely.
And what we'll talk about next week is is where you're going, but just take a look at that Lawton Burns piece in preparation for next week. This is a great introduction to next week.
So I had the misfortune.
Required video.
A required video as well.
Yeah.
With Lawton Burns talking about this.
I had the misfortune
I've gotten
just
you ready to see the video.
after I'd been to India. I had the misfortune that I had to accompany a friend of mine who got sick in D.C. and I had to take her to the ER at George Washington University on a Friday night.
Oh, God.
I don't know, there were like 15 patients or something. It was not like really bedlam, you know, like you'd see in some places. But there was like 15 patients, and it must have taken like, I don't know, 5 hours before she was seen, okay? And it was one of the questions I asked already, and I said, I don't get it. I mean, I don't understand how you're seeing 4,000 patients a day in the outpatient and there's no waiting list. I mean, it doesn't make sense. I mean, this is like physically impossible. Maybe I don't believe that you're seeing 4,000 patients. So then he said, have you ever flown through Heathrow Airport or John F. Kennedy Airport? I mean, they process tens of thousands of patients, of people a day.
Kennedy might be a bad example.
Heathrow.
Stick with Heathrow.
Yeah, okay, whatever. So he says, well, you know, you figure out the flow, right? You figure out the flow of things. He said, you figure out the flow of things in the operating room. You figure out the flow of things in the cataracts, and you do process engineering. And I said, well, where did you learn this stuff? And he said, well, we went to where? Where did he get this?
Philly.
Definitely not. Definitely not Goldman Sachs.
Disney.
No.
Hey, they do that really well.
Germany.
Henry Ford.
Okay, they went to Sweden. Okay, those of you who know, Sweden has perfected process engineering. You know, in the industrial sector, not in healthcare, but
Them IKEA.
yeah. Absolutely. But you know, so they said we went to Sweden and we studied their process engineering, And we said, there's no reason why you don't process patients the same way you would process an airport or other places where you have high volume. And you just work out the system and then you implement it. Now, I
Especially
didn't
patients-
ask him about patient rapport, whether or not I sat down and talked to the patient, so there's many other things. But we're talking about reform. I mean, what is this beast we call reform, right? So if you want high end, they've got it in India. If you want low end, you got it in India. So India wants to make more access to care. So what's the thing that they've now done to try and improve the access to care? Because they have actually done something. I don't think it was in the article, actually. I don't think it was. Yeah, you probably know, right? Because you're,
So, like they have two biggest programs, which is like NRHM, National Rural Health Mission, and then other one is Rashtriya Swasthya Yojana Mission, which means like National Health Program kind of thing. So
it's in the article, actually, what I'm
yeah,
referring to.
it's RSY.
RSPY.
Yeah, exactly.
Okay,
Rashtriya
well, how does that work?
Swasthya.
Because it's important to our conversation.
Yeah, so this is basically more focused on the federal and the state intervention level and
But
lesser.
what are they trying to do?
They're trying to build a platform for universal coverage for access and affordability, but it's still.
No, but concretely, what did they actually do?
Pay for hospitalizations.
Sorry? No.
They don't pay.
No, it's.
What concretely do they do? Because it's very important, because it relates to what we're doing here in the US with the Obama reform.
They're actually just, I think they're working on the reimbursement and the payment reforms, like how.
But the key thing is, they say that patients can't afford access, they can't afford the care. So
More-
we're going to give poor people a subsidy.
Subsidy, yeah.
So they can belong to insurance programs. So it's a very interesting reform, because what they're not doing is, so 1948 you had a nice national health service, everybody had access to care, and you had clinics and whatever have you. British National Health Service supplied subsidy, okay? Didn't work. So, 60 years later, India says, let's not do that again. Let's do something that maybe works. Let's subsidize not the providers, let's subsidize the insurance program. So that way, the poor people have insurance, and now let them choose where they want to go. They can choose where they want to go. You don't have to go to a government clinic, you can go wherever you want, but we're gonna make sure you have insurance. Kind of an interesting idea. It's the same as Obama reform, right? You go to an exchange, the people who can't afford the exchange, you give them a subsidy. Once you have your insurance, you're not forced to go to NYU hospital, you can go to Columbia,
You're in a network, you're in a network.
Or you might be in a
Yeah, except that the talk I went to this afternoon suggested that the vast majority of people getting care through the exchanges are in these extreme narrow networks, actually.
Probably, yeah.
They cover like 25% of the
Right.
providers. in
But
Kashmir.
technically, it's open, it's not closed, not like Britain, you have to go to this hospital, I mean, you're technically open. So, very similar to what we did here, actually. Let's flip over and look at China just for a second. Hold on, we have to be careful about when I have to finish, soon, right?
It would be very good if you could finish in 10 minutes.
Yeah, perfect. So I want to flip to China for a second. So I just want to say, India then decided to do something which is very market-oriented, okay, very market-oriented, very dynamic compared to what they had before, but with the objective of we have universal health care in India. We're not going to make it better because the universal health care we have in India today doesn't work. It excludes people because the rich people are not going to go to these public clinics, and the poor people actually don't want to go there either. So where do the poor people go? They go to the private clinics. Exactly. Poor people don't want to go. I mean, poor people are not stupid people. Okay, anybody who's worked in developing countries, poor people are quite bright. Okay, and they know that their neighbor's wife got killed when they went into one of these places, and she gave birth and she died in birth. People know that, okay? So they don't want to go into these places because they are death places, okay? No, that's what it is. I mean, these places are death places. And so the idea is now you empower, so it's really consumer-oriented, it's a consumer-oriented kind of thing. We're going to empower the patient to make the choice.